And I'm going to talk about mobilising computable knowledge, challenges for clinical decision support from a medical knowledge provider. And I work for BMJ, mainly for BMJ best practice, and much of what I say is going to be related to BMJ best practice. Not all of it, but a lot of it. BMJ best practice is clinical decision support, knowledge resource that provides knowledge at the point of care that we're continually updating, evidence-based and practical. And so we face multiple challenges. The first challenge is just it's an enormous job. We create 1,200 topics. There's 10 million words there in several different languages. So it's a massive amount of work to create this content, keep it continually up to date because the knowledge base is continually changing, keep it evidence-based because the evidence base is continually changing as well. So we can't make it all computable, so where do we start? And we don't know where we start. So I often think of David Smith writing in the BMJ over 40 years ago when he said, the objection that I have to much of my medical education is not that I memorize things, but I memorize the wrong things. And I think for a modern version that not that I made things computable, but I made the wrong things computable. We need to make sure we make the right things computable. Outcomes research, we're keen to hopefully trace how our computable knowledge and decision support impacts patient outcomes. And to do that, we need more and better collaboration with analytics, informatics, EHR providers, teams. But that's often slow because they don't sometimes have any incentive to work with ourselves. And also, as somebody has said, it means working with data that's current, accurate, meaningful, useful, and usable when we know so often it's not. But I know data's out of scope for computable knowledge, so I'll move on. Localization. So we provided global, international, evidence-based content, and we provide it to hospitals or countries or regions who then say to us, it's great, we really like that, but what about our own local content, our own local guidelines, protocols, and our department, hospital, country? And that actually might be an opportunity for computable knowledge, because it's hard to do that at a document text level, and machine-readable content may be a solution. So it's something we're actually working on actively at the moment. What about creating machine interpretable content? So clinicians write our content for us, and we want active clinicians to write the content. How do we ensure that we encode what they intended? Is there enough capacity in the UK to enable this to happen? So Francis Bacon, writing many years ago, wrote, "Reading maketh the full man, conference ready man, and writing an exact man." And I like the last little bit, writing an exact man. How prophetic he was when he said that. And yet, it's a struggle for us to get authors to write anything or to write clearly. It would be an enormous struggle to get them to write computable knowledge or even to write knowledge that we could easily make computable. So that is a massive problem, not just BMJ, but in the UK in terms of capacity. Standards, there's been a lot of talk about standards, so I'll just touch on this. But obviously it's a risk and a challenge to medical knowledge providers that we can become unstuck. But developing against one standard and then find out there's no interoperability and we cannot transfer. Medical devices I'll pass over. Comorbidities. Interestingly, one or two people spoke about comorbidities, but relatively few. Brendan, I think you mentioned the fact that loads of patients have multiple conditions, and yet care pathways, guidelines, papers, they only deal with single conditions. Can computable knowledge resources help in this regard? We're working on something at the moment, which we've launched in pilot sites. And I don't have time to go into any great detail, but I think it's a shocker, really, that most patients over the age of 65 have more than one condition. They're the highest users of the health service, and yet we're still providing single disease knowledge resources. Safety at the point of care. So safety standards must be followed, and we follow DCB 0129. But it takes a good deal of resource to do that properly, and it must be clinically led and integrated with everything else that we do. So Jeremy was saying that this morning, he was dividing between explicit knowledge and tacit knowledge, as far as I can remember. But say we were to solve everything in computable knowledge in healthcare today, would we have solved everything? Well, Byron wrote that the tree of knowledge is not that of life, which is very true, because it doesn't take into account problem-solving procedural skills, healthy attitudes, professional behaviors. And I think it's artificial to divide explicit knowledge from all these other things that a doctor needs or healthcare professional needs to develop. I don't think you can divide them. I think the job of a healthcare professional, a good healthcare professional, is to integrate them, actually. So I'm not too sure, is it right? And I also wonder increasingly about what's the role of the doctor in the new world of knowledge, with knowledge continually at their fingertips, which changes things. And often in talks like this, people will say, oh, a systematic review showed this, or oh, there's evidence that that is the case. And I'm always very skeptical about things like that, because often a systematic review will go back 20 years and look papers that are 20 years old, where people were using completely different technologies to what we're using today. So I'm skeptical about looking at anything that's more than 5, 6 years old, because just the world of knowledge is completely different today than it was a few years ago. And back to knowledge, so I'm concerned that we try and separate it out. So let's play a game. Anybody play Ex Libris? Anybody play? Some people in the audience. So the rules of Ex Libris is, I say the first line of a novel, you shout out what the novel is, who the author is. Okay, we'll do a test one. Test run, call me Ishmael. Author. Herman Melville, very good. Facts, facts, facts. Now what I want is facts. I will teach you the facts, and at the end of the year, I will test you on them and nothing else. Nobody gets this anymore. I'm going to have to change this one. Charles Dickens' Hard Times. Mr. Gradgrind, you've got it. Very good. Okay, we'll give you half a point there. So I asked myself, is medicine ready for computerized knowledge or computable knowledge? So we often get enthusiastic junior doctors into BMJ, want to do projects in computable knowledge and informatics, and they tell us that they have less than enthusiastic seniors who are sometimes not knowledgeable, who don't value or don't encourage them, or sometimes actively discourage them, or say maybe you should do something more traditional biomedical knowledge. So they come up against institutional barriers in their institutions. So I like these quotes from John Rowan Wilson a few years ago now, but not that many years ago. He wrote, "The college occupies a tiny Vatican in XXX." You notice I've anonymized that, I don't want to offend anybody. Whose benign soft-footed cardinals pad around discussing preferment of one kind or another. And he also wrote, "Fellowship at the college is decided by examination, and theoretically all fellows are equal, just as theoretically all officers are gentlemen." Usually at this stage in the talk, people start to shout out and say, that's the Royal College of Physicians of Ireland, isn't it? Or no matter where I go, they say, that's Harvard, isn't it? They never say, is that us? So I worry about the culture of medicine, and are we kind of blocking people? So Kairat et al., writing last year, wrote about reasons for physicians not adopting clinical decision support systems. And the reason why, lots of different reasons, but often they ask themselves, why are they getting alerts? Whether the clinical content they're seeing is evidence-based, what point in an algorithm there might be, and they say clinical decision support is a black box to a physician. Somebody else said a black box, Deepak, wasn't it? Yeah. And so we want to make things much more transparent, to reveal how output decisions are made, and we hope that might overcome lack of users' acceptance. 4 years ago, Islam wrote about understanding complex clinical reasoning in infectious diseases for improving clinical decision support design. And he said, maybe if tools were designed to share decisions, to take burdens off clinicians, to enable shared decisions amongst colleagues or between physicians and patients, it might be better, we might get better buy-in, we might get better usage. We're sure of one thing, which is we can't do things alone, and so we need partnerships. And so I hope I've done it in 10 minutes. It's always a challenge to speak in 10 minutes. Eugene Mill, also writing in the BMJ in 1985, wrote, "A first-year medical student recently commented to me that every lecture he attended, he fell asleep after 45 minutes or so. Of course, with my years of experience of medical education, I assured him that with time and some effort, he would be able to achieve this in as little as 10 minutes or less." So it's reassuring to look out at all of you and see you're all still awake. So thank you very much indeed for listening, and thanks for the invite.
John. Thanks. Kieran, that was fantastic. There's a list of things that this community, I think, needs to discuss in depth and understand. I think that was tremendous. I'd like to pick on one in the spirit of provocation, perhaps. It's not intended to be hostile, but I think a really important question. And it's about BMJ as a commercial company, in which when you create knowledge, you invest a lot of company resources, and at the end of it, that's a property which is proprietary, content which is proprietary, and you're naturally, like other publishers, very defensive of that. Do you think that as we create repositories of knowledge at the level of authority that BMJ commands, the scale and the authority, that we should be doing that in a commercial context, or should it be done in the public domain in which the content is publicly owned?
So I think it depends. So BMJ is a decent-sized organisation. We publish, it's divided into two. There's a journals division and there's a knowledge division. The journals division is kind of quickly moving to open access. So 10 or 15 years ago, I think we had, well, I don't think we had any open access journals. Now we've got 10 plus open access journals, and I think over the next 2 or 3 years that will change really, really rapidly. The knowledge division, then it's behind paid access controls. It's sold to institutions, ideally kind of big institutions or consortia, so they can get value. In resource poor countries, it's made available free, or middle-ranking countries at very low cost. I guess a business model is a challenge for medical publishers, but it's changing, like it's changing for all publishers. So I know I'm not completely directly answering your question, but I think watch the space in 5 or 10 years' time.
I think it's a fair answer, and probably the best that somebody in your position could do. Everybody has shortcomings, but I would think we're following open access, open source as a model for open clinical, because we want all that knowledge. We want it to be not only transparent but accountable to other people who are authoritative or more authoritative, who can judge whether your diabetes pathway is safe and appropriate, and what constraints are and should be on its use.
Yeah, that's a fair point.
There's an important discussion.
Thank you. I'd like to enter that debate if I could, only because it was only last night that I was writing an email to somebody saying that we're going to have to explore something that has an echo to the interaction you've had. So I'm running a not-for-profit institute, and we are looking to hold a set of knowledge assets that have been developed through a project in order to make them more widely available. And the question I was asked was, can I just check with you that it is your intention to host these and make them available to the public? And my reply was, yes, we intend to host them. Yes, we want to make them available to the public. Whilst we would like to make them open and free, there is a maintenance cost to be found, and we will need to first discuss with colleagues whether we have to require a fee that brings us that income, or whether we can get sponsorship that allows them to be free for access. So the business model issue is probably one of the two more important questions than the organization. The second important question that didn't arise in your interaction is the degree to which the commercial entity, whether you're hosting the environment or funding it, because there are also plenty of great companies that will sponsor activities is the degree of separation between the potential interests of the sponsor and the people who are decision makers about what goes on. So really, John, the key questions behind your remark should not be, is the organization commercial, but what is the degree of independence and transparency about decision making in what it does? And B, is there a transparent and acceptable business model behind the genuine costs that are incurred?
Yes, so that's a fair point. So editorial independence is core value to BMJ. So we do accept advertising and sponsorship, say for our meetings, for the journal, but there's a line that the advertiser aren't able to cross, and the editorial content is completely independent of it. And also, we insist on transparency, so we insist that our authors declare any financial or non-financial competing interests that they might have.